Welcome to the History of Retina's Leaders and Legends series. The purpose of these interviews is to capture first-hand stories from individuals with unique retinal insights of historical significance. Through these discussions, we hope to provide a fuller understanding of the evolution of both the science and practice of retina through the lens of those individuals who have actually lived it. It is my great pleasure to be joined today by Dr. Stuart Fine. Dr. Fine is the Emeritus Professor and Chair of Ophthalmology at the University of Pennsylvania School of Medicine and the Emeritus Professor of Ophthalmology at Johns Hopkins Hospital, Wilmer Eye Institute. World-renowned for his leadership in education, research, and patient care, Dr. Fine has received many of our field's highest honors. But he will tell you that he is most proud of his mentorship of 2 generations of medical students and house staff, many of whom have become national and international leaders in academic ophthalmology. A true pioneer and preeminent investigator, Dr. Fine helped shape the field through his leadership of numerous National Eye Institute-supported, multi-centered clinical trials to evaluate new and existing treatments for retinal disease. Stuart Fine was educated at the University of Maryland and its School of Medicine. After completing a residency at the University of Florida, he was an NIH Fellow in Retinal Diseases at the Wilmer Eye Institute under the mentorship of Dr. Arnold Patz. From 1973 to 1991, he was on the full-time faculty of the Wilmer Eye Institute, where he served as Professor of Ophthalmology, Director of the Retinal Vascular Center, and Director of Medical Student Education in Ophthalmology. In 1991, Dr. Fine assumed the chair of the Department of Ophthalmology at the University of Pennsylvania and the directorship of the Shea Eye Institute. During his tenure at Penn, he dramatically expanded the ophthalmology faculty, the annual research budget, the number of endowed chairs, as well as both the clinical practice and the educational programs for the residents and house staff. After 2 decades, Dr. Fine retired from Penn, but continues to cultivate the next generation of retina leaders through his work as a clinical professor of ophthalmology at the University of Colorado School of Medicine. Dr. Fine, thank you so much for joining us today. It's really a pleasure to have you here.
Pleasure to be here.
So I want to start with going back a little ways to talk about what drove you to medicine first, and then we'll talk a little bit about what brought you into ophthalmology.
It starts probably when I was 5 or 6 years old in the 1940s when pediatricians made house calls, when mothers called and said, my child has 102 and he's coughing. And even though the pediatrician's visit was typically accompanied by a shot in the rear, usually of penicillin, I always look forward to the pediatrician's visit because he would play with me, ask me what books I had, we'd play with marbles, and from the very early age, I said to myself, or thought to myself, I really like the way doctors interact with patients, makes them feel better. And then I said, well, what do I have to do in order to be a physician? Oh, I have to take biology and chemistry and so forth. I'll do that. It was the heart of the Vietnam War. I was married with a young child, and I said, how am I going to avoid going to Vietnam? And the answer was, get into the public health service. And I worked very hard on the telephones, presenting myself to various people, and I eventually found a position in the U.S. Public Health Service, which would start after completing my internship. I had never, ever taken 1 iota of ophthalmology in medical school, but lo and behold, I wound up in the public health service in an office with a young man who had just completed his chief residency at Hopkins, Mort Goldberg. He happened to be dating a woman that I had dated in high school, whom he married, and we became good friends. He became my mentor. I was introduced to ophthalmology at the very highest level, and by the fall of that year, I was ready to say, maybe I'll give it a try. a very circuitous, unusual path, pure serendipity, like so many other things that determine our lives. You happen to be in a certain circumstance, and you say, yes, I think I'll follow that path.
It seems like the Public Health Service was sort of a unique opportunity for you to explore ophthalmology with a remarkable person.
Absolutely. And what really polished off the whole idea of ophthalmology was my engagement with the Early House Symposium on the treatment of diabetic retinopathy.
Could you tell us a little bit about that? Because
Well,
that we know was a pivotal moment in our
yeah,
entire history in a way.
yeah. I remember like it was yesterday. It was in the summer of 1967. I read an article in the New England Journal entitled Hypophyseal Stalk Section as a Treatment for Diabetic Retinopathy.
Most of our younger doctors have never heard of this.
Exactly. But pituitary ablation at that time was the chief and only treatment for diabetic retinopathy. I read that article 3 times, made no sense to me. I walked down the hall to Mort Goldberg's office and I said, "Are you aware of this?" He said, "Yes." I said, "Makes no sense." He said, "Well, no one knows if it's effective or not." He said, "There's another technique called photocoagulation." What's that? He explained that to me and then referred me to a paper on photocoagulation for sickle retinopathy that he and Dr. Bob Welsh had recently published. And so I read that, and then he said, our program ought to sponsor a symposium, an international symposium, where we bring together endocrinologists, neurosurgeons, and ophthalmologists to talk about the treatment of diabetic retinopathy. We presented that idea to our program chief, and in collaboration with the chief of the Diabetes Control Program, also in the Public Health Service, those 2 program chiefs agreed that Mort and I would plan an international symposium. So that was the beginning.
You also set that meeting up in a unique way, thinking about how maybe to evaluate and classify. You asked people to bring their materials even before they arrived to share.
We did. The first thing that took place, actually, there was a meeting at O'Hare Airport, and the participants in that meeting were ophthalmologists who had been involved in writing about diabetic retinopathy. For 3 days, we met at the O'Hare Airport and hammered out a new classification of diabetic retinopathy, which became known as the O'Hare classification. Eventually, that morphed into the Early House classification and then the DRS classification. So that was the first thing. We then sent that classification to all of the ophthalmologists who had agreed to come to the symposium, and we asked them to send us data about the outcome of treatment either with hypophysectomy or photocoagulation using that classification. We asked them to send their publications and photographs to us in the Public Health Service. We duplicated all of that material and sent it out to all the symposium participants several weeks in advance of the meeting. At the symposium, which was held over 3 days at the Airlie Conference Center in Warrenton, Virginia.
And that in itself changed a lot of the thought about how to manage diabetic retinopathy, correct?
It was abundantly clear at that symposium that there were no good data demonstrating that patients treated with pituitary ablation had any significant benefit from that treatment, and there were many, many, many side effects from patients being panhypopit. And the third outcome was it really created the impetus for the diabetic retinopathy study.
That trial changes how we look at clinical trials in general in ophthalmology, but it also changes how we practice. So how did that happen, and how did you disseminate that?
Well, the first paper for the URS was published in the American Journal of Ophthalmology in April 1976. And I'm fond of saying that there were 2 main outcomes of the DRS. The first, and I guess the most important, was the documentation that pan-retinal photocoagulation could reduce by more than 50% the likelihood of blindness for patients with proliferative retinopathy. The second and almost equally important outcome was to convince ophthalmologists really the world over. I don't even want to say the value of randomized clinical trials, the necessity of prospective randomized clinical trials to evaluate new and emerging treatments for any condition.
So take me from your public health service at the Early House through your early training after and your career.
After the Early House Symposium and my 2 years in the public health service, I then started my residency at the University of Florida. And I knew even before I started that I was going to be a retina specialist because it was my interest in diabetic retinopathy, in fundus photography, in fluorescent angiography, and photocoagulation that got me interested in ophthalmology. And then I decided to apply for retina fellowships. And I did that. This was long before the match for either residency or for fellowship. I did that by writing to 3 people that I had met during the Early House Symposium: Ed Norton at Miami, Ed Oken in St. Louis, and Arnold Patz in Baltimore. But when I wrote a letter to Doctors Norton, Oken, and Patz about my desire to do a retina fellowship, I said, I do not want to do retinal detachment surgery during this fellowship. I said, what I want to do is examine patients with diabetic retinopathy, macular degeneration, retinal vein occlusion, angioid streaks, choroidal nevi, melanoma. I want to become proficient at interpreting fluorescent angiography. I want to learn how to do laser photocoagulation, which was just in its infancy, and so forth. And the first call I got was from Arnold Patz, who called me over Thanksgiving weekend in 1971 and said, I got your letter, and I hope you will come up and visit with me because I'd love to have you come here. And so that's what I did. And it was the beginning of a career that lasted more than 40 years.
Lasers are so ubiquitous now, but at the time, lasers were hard to come by in practice, correct?
Oh, I think there were, on the East Coast, maybe 4 lasers. And the consequence was that Arnold and I were seeing 50 or 60 patients a day from all over the country, and some from Europe, with proliferative retinopathy, the worst retinopathy that you could ever imagine.
How do you put that all together, and where does laser fit into that and clinical trial?
Well, we were a little bit like the proverbial man with the hammer and everything looks like a nail. The argon laser was our tool, and we were experimenting with treating it not just for proliferative retinopathy, but for macular edema, for choroidal neovascularization, for central serous, for patients with macular edema secondary to retinal vein occlusion, and so forth. It was a very, very exciting time.
So go from your fellowship experience to your faculty.
Baltimore is my home. That's where my wife and I grew up, and we were delighted to spend what we thought was just going to be 1 year there for a fellowship. I had met Matthew Davis when I was in the public health service. He was still the chair of ophthalmology at the University of Wisconsin. I met Mort Goldberg in the public health service. He was the chair of ophthalmology at the University of Illinois. So I wrote to them and asked if they might have a position available for someone who would have my skill set. And they both wrote back that they were very interested, and they invited me to come out to give what's commonly known as a job interview. And I was preparing to do that, and it was going to be right after the academy meeting in 1972, just 2 or 3 months after I'd started my fellowship. And I had a meeting with my mentor, Arnold Patz, and I just wanted to review with him what I was going to be talking about there, show him my slides. And then he said something that shook me. He said, would you consider staying on with me instead of going to Chicago or Madison? Well, I loved working with Arnold Patz. I loved being at Wilmer. I loved being at Hopkins. I had a wife and 2 young children who were then living in Baltimore with 2 sets of grandparents. I mean, what could be better than that? Once I had that offer from Arnold Patz, there was very little doubt that I was going to stay in Baltimore. And I did for nearly 20 years.
Many of our younger listeners don't appreciate what role you played in mentoring future ophthalmologists from Hopkins. So I say over and over again, I'm an ophthalmologist because of the time I spent with you. So tell me a little bit about how you became the person you were that influenced a generation.
Well, I will tell you first, it was a labor of love. I always felt it was a privilege to teach medical students as talented as the Hopkins medical students, and in the second part of my career, the University of Pennsylvania medical students. I came about it because there was a fellow named Harold Cross, MD, PhD, who had the responsibility of teaching medical students. And in my second year on the faculty, he came to me and said, I've just accepted a position to be the chair of ophthalmology at the University of Arizona. How would you like to take over the responsibility of teaching the medical students? And I asked what it involved. He said, it's very little effort. He said, on Wednesday afternoons, the students on pediatrics come over to Wilmer, and I just give them a couple of talks. I figured I can do that. And then I thought a little bit to myself. I said, that doesn't sound like a very good rotation. So I expanded. I did 2 things. First of all, I began to give the students some clinical experience by sending them to the clinic to work with residents, to work with faculty members, and to the OR. And secondly, I expanded the 18 hours a week, 9 times 2 hours, to 36 hours a week. After a year, I went to the curriculum committee and I said, we're doing 36 hours a week of ophthalmology. It's almost a 40-hour week. I think we should have 1 full week out of the pediatrics rotation. The head of the pediatrics clerkship said, that is impossible. We cannot give up the students. We need the students for rounds every day. They bring the x-rays to rounds. They go and get the lab values. And I said, wait a second. You're telling me that these students who are paying thousands of dollars a year, you want them to be available to bring the x-rays and the lab values and not to have a fabulous educational experience in ophthalmology? He was dumbstruck. The curriculum committee voted unanimously to give us 1 full week of ophthalmology out of the pediatrics clerkship. Within a couple of years, we had up to 20% of the class of 100 applying for residencies in ophthalmology.
And that was a model for programs around the country, essentially. But you also had such a personal touch with the students that you were involved with at a medical student level when many senior faculty and junior faculty really didn't feel that that was an important contribution. So how do you understand so early in your career how important that time is? Because you've changed lives at that level that went on to change lives throughout the country.
I didn't think about it that way, Tim. I did it because I enjoyed it. The other thing I did, which I don't know if anyone does anywhere, I did this at Hopkins and at Penn. I met for an hour to an hour and a half with the whole group of medical students on that 1 week rotation. And I asked them what they were thinking about for career choices. That's how I put the question. And I said, no, when you're thinking about the future, I said, are you thinking about anything other than clinical practice? Because there are so many other things you can do with a medical degree and with your subspecialty training. You can do clinical trials, you can do epidemiologic research, you can do laboratory research, you can do public health ophthalmology, and on and on. I said, and ophthalmology is one of the few fields where you can become very competent in a clinical area, even in a surgical area, and then devote a certain amount of your time to some other pursuit, such as epidemiologic research. You can't do that as a cardiac surgeon or as a neurosurgeon or as an orthopedic surgeon. And that got a lot of people thinking about the opportunities that would be available to them if they had training in ophthalmology and then pursued an academic career.
And the other thing that I think you've done with that is that you cast a net widely. So you brought people in from different disciplines, it seems to me, in a way that allowed everyone to flourish. Speaking of epidemiology and biostatistics, clinical trials design. So who did you start bringing into that team with you early and why?
I mentioned earlier that the original diabetic retinopathy study publication was in April 1976 in the AJO, and that was the demonstration to the world of ophthalmologists that clinical trials were important. And so I decided within a year or so to write a proposal to study or to evaluate photocoagulation, laser photocoagulation in particular, for choroidal neovascularization in two separate conditions, macular degeneration and the ocular histoplasmosis syndrome, which was quite prevalent at that time in the eastern half of the United States at least. And I knew that I needed a coordinating center to assist me with this. So I went over to the Maryland Medical Research Institute at the University of Maryland, which had been the group that coordinated the diabetic retinopathy study. I was assigned to work with a young biostatistician named Dr. R.G. Hillis, and I worked with her for a few months preparing the grant application for the National Eye Institute. About 10 days before the grant application was due, Dr. Hillis called me and said, I am leaving the Maryland Medical Research Institute today. I'm sure they will appoint another person to work with you. But if you're willing, I would be very happy to work with you as an independent contractor. So I called Bethesda and made an appointment the next day to meet with Dr. William Raub, who was the deputy director of the National Eye Institute. And I explained the situation. He said, in fact, Wilmer ought to have a full-time biostatistician. So if you can get your chief, Dr. Malmedy, to offer her a job, I will guarantee at least 50% of her salary, even if the grant is not funded, because RG was in on that grant for 100% support. So I drove back from Bethesda to Baltimore. I met with Dr. Malmedy for 5 minutes while we were walking to another meeting, and he said, what's on your mind? And in 5 minutes, I had to tell him the whole story. And he said, fine. He said, what would her salary be? And I picked a number. He said, fine, we'll hire her. And that was the beginning of biostatistics at Wilmer. That was the beginning of the Wilmer Clinical Trials and Biometry Center that eventually had 4 remarkable people there, all of whom became my collaborators, and without whose collaboration, my career would not been as nearly as robust as it has been. And the others, of course, were Barbara Hawkins and Maureen McGuire and Marie Diener West, all brilliant, all without ego, self-effacing, wonderful human beings, and brilliant and accomplished in their fields.
Take me through how you enter in the collaborative ocular melanoma study where now you're reaching out to pathology and radiation oncology physics. So you're moving out of traditional, potentially medical retina.
Yeah.
How did you negotiate that?
I'd been interested from very early stage in choroidal nevi and the evolution of nevi into choroidal melanoma and the treatment of melanoma. And the standard treatment was enucleation. And at the same time, there were several people around the country who were performing an experimental treatment, treating patients with choroidal melanoma with a radioactive plaque, originally with cobalt and subsequently with radioactive iodine. And I thought, this is a perfect example of a condition where it's reasonably accurate, not 100% to get a diagnosis, but tremendous difference of opinion about when to treat and how to treat. It just sounded like a perfect example for a clinical trial. It was a rare disease, so I knew we would have to have many clinical centers participating in order to be able to recruit a sufficient number of patients.
I still to this day think how unique that was, particularly in the field that required a surgical treatment.
Yeah.
So what were some of the hurdles there, and how do you think you addressed them?
I think I was able to put together um, what would be called an A list of people who were interested. And then once I had that group together, I began making calls around the country to retinal surgeons who saw a few patients each year with choroidal melanoma to try to see if they would be interested in participating in a clinical trial and if they thought they would be willing to learn the technique and to enroll patients into a randomized trial. And there was zero resistance and great enthusiasm for doing this because intellectually, people knew that this was the right thing to do.
Move me forward. So I kind of thought that you would be at Hopkins forever. So
Everyone did.
you were an institution. So how do we get you out of Hopkins, and take me through that next step?
I had complete control over the medical student experience, but I didn't have much say about the residency experience. And I thought I had some ideas about that. And so I said, maybe I just need to be a chair. And so when the opportunity came from the University of Pennsylvania, I decided to go and look. And it was a good decision. I had almost 20 years at Wilmer. I loved my years at Hopkins. By the time I went to the University of Pennsylvania, my daughter was out of college and married. My son was a senior in college. And so it was a good time to move.
What do you think were some of the early challenges? What do you think you brought to that uniquely that allowed you to flourish there?
There was a lot of opportunity. I knew that a department can't be excellent in everything. It has to be competent in everything. And I decided I wanted to be excellent in retina and retinal degeneration, to be excellent in epidemiology and biostatistics and clinical trials, to be excellent in neuro-ophthalmology. And on the research side, I knew I wanted to be excellent in the whole emerging field of gene therapy. And that's how I came to get Albert McGuire and Jean Bennett. That was the beginning. It took a number of years, but as you know, gene therapy for an inherited retinal degeneration, to my knowledge, and I may not be au courant, is still the only gene therapy that's been of proven benefit for patients with an inherited disease, certainly in the field of ophthalmology. And it was very exciting to see that develop over the years.
Stuart, you've done so many remarkable things, and I think there's a lot for you to look back on at virtually every aspect of your career. Could you touch on what you think are a few of those moments that really have impacted you and our field?
I love the fact that I seem to have had an influence on many, many medical students, dozens, who have pursued a career in ophthalmology, and not just pursued a career, but become leaders in ophthalmology around the world. I'm also proud of the clinical trials that I chaired, the groups that I put together, knowing that a number of those clinical trials really changed the practice of medicine in a very meaningful way. I'm also proud of some of the things I did as the president of the University Professors of Ophthalmology. And one of the things I introduced was the annual AUPO Resident and Fellow Research Forum. The AUPO annual meeting used to be strictly a business meeting, and I said, we're an academic organization. We ought to have some science and some clinical research presented here at the annual meeting. So initially, with some reluctance, the board agreed that there'd be 60 to 90 minutes every year of presentations by outstanding proposals submitted by residents. So those are the things I'm most proud of as I reflect back. Of course, the hundreds, maybe thousands of patients that I saw, but every doctor is proud of that.
Wonderfully said, Stuart. Thank you for joining us.
Thank you for having me.